Sir.
Yes, sir.
The renal replacement therapy, the type indications actually you can be to classify them into renal and non-renal, or indications in acute and chronic disease. Whichever way you want to classify, you can say the indications of RR can be classified into renal and non-renal. And the mnemonic for remembering the renal factors are U-FAKE. U stands for uremia or azotemia, uremic encephalopathy, or all the complications of uremia like pericarditis, hemorrhage, and urea level more than 30 to 35. FAKE stands for fluid overload. So oliguria resulting in clinically significant volume overload, which will lead on to respiratory distress and cardiac failure ultimately. Initially, it can be treated with medical management by the heavy doses of diuretics and fluid restriction and all these things. But if it is not responding to that, we will have to remove the excess fluid only by renal replacement therapy. The third condition is metabolic acidosis, which develops in renal failure with a pH less than 7.2, retention of acids and hyperfluoridemia, tubular dysfunction. All these things lead to that. So that forms the A of the FAKE. And the last one is K, kalemia, hyperkalemia. So remember these four things: uremia, fluid overload, metabolic acidosis, and hyperkalemia. These are the four renal causes of indication for renal replacement therapy. That E stands for extra conditions, which are can be classified as non-renal, where toxins like drugs, small non-protein bound agents like toxic alcohol. Today, there is a hot news going on about the death due to arak, the poisonous arak, which contains methanol. So many patients are on dialysis to remove the methanol that has been ingested by them. So the toxic alcohol, lithium salicylate, theophylline, valproate, all these drugs can be, if they have been ingested in excess quantity, and if that is going to cause the problem, that can be removed by renal replacement therapy, more to sustain life rather than to replace. Here the kidneys are functioning, but these toxins can affect the function of the kidney. So we want to remove them by dialysis. Actually, the kidneys are not in problem here. So it can be called as non-renal indication. Similarly, hypernatremia, where the sodium levels goes to 160 millimoles, that also is an indication for removal. And temperature control in hyperthermia, that is also a way of cooling the patient and removing the doing the dialysis. We can cool the patient. It is something like an extracorporeal circulation cooling. And in sepsis, to remove the inflammatory markers or inflammatory glycoproteins which have been formed, removed by the various techniques of renal replacement therapy. So it is better to classify them as renal and non-renal, the indications for that. And the type of renal replacement, first is the hemodialysis. There are several forms of that, which we will see now. The peritoneal dialysis also, before the advent of hemodialysis, peritoneal dialysis is the oldest technique of renal replacement therapy. So in acute conditions, they used to do emergency peritoneal dialysis depending on the, based on the exchange properties of the peritoneal membrane and the capillaries, the blood vessels that are present in the abdomen. And the third is the renal transplantation, which is a definitive and a prolonged, much more safer and permanent relief for the patient, unless the transplanted kidney goes for rejection or anything. This will be a much more prolonged treatment of renal replacement therapy. So we have to mention all the three modalities as a part of mode of replacement therapy. Now, how are these solutes and fluids removed? There are two techniques. One is called hemofiltration and the other is called hemodialysis. which you described very well. But these pictures will help to understand this process very well. In the hemofiltration, the blood of the patient is passed through a filter. These filters are called the actual kidneys. In the dialysis machine, if you see, these filters are called actually they do the function of all the nephrons. So they are called the kidneys of the machine. So patient's blood is drawn out of his body. Extracorporeally, it is pumped into the patient through a filter at high pressure. So there is a positive hydrostatic pressure where the blood comes in. And there is a semi-permeable membrane. There is a gap here in the side of that filter kidney. And because of the pressure, what happens? Water and mainly water alone goes into the empty compartment here. And along with the water, some of the solutes also will be taken. That is what we call the solute drag. Okay, so if you are able to draw this picture, then it will be much more easier. Even if this filter you need not draw, you can just put this line diagram separated by a semi-permeable membrane. Blood is pressurized and sent into this filter, and because of the hydrostatic pressure, water will be just pushed out into the negative space, and you can see in this picture there is no extra fluid added into the kidney. That is the main thing about it. Is just like filtering your tea when you make a cup of tea. So you boil the tea and the tea dust and in water, and then you pour it onto the filter and retain all the tea particles and filter out only the tea decoction and then mix it with milk or take it plain like that. The same mechanism here, the blood is pumped at a pressure into the filter, and because of the semi-permeable nature of the membrane, water is pushed out. Along with that, it drags smaller molecules, and then whatever has been filtered is sent out. This is the filtrate. And this process is called the convection process. And the whole thing is called hemofiltration. So remember your tea filtration, and you can easily answer this by hemofiltration. Uh, so here the blood is pumped through an extracorporeal system that incorporates a semi-permeable membrane. The hydrostatic pressure that is created on the blood side drives the plasma water across the filter. This process is referred to as sometimes also as ultrafiltration. And the molecules that are small enough to pass through the membrane. So the pores of this semipermeable membrane through which small particles shall be dragged across the membrane with the water by the process of convection. So the water going out from the blood into the empty space is ultrafiltration. The solutes being dragged along with the water is the convection. So there are two processes that are going in this mechanism. So the filtered fluid is discarded, and whatever, because you are losing the volume. So if the patient goes in for hypotension, or if the discarded volume is too much, you can replace that fluid with the desired fluid balance and the when you pump the blood back into the patient, you can add the fluid and replace the volume, whatever is necessary to the dependent level. So that this is mainly done to remove the excess water. So most of the time, patient may not require any other additional replacement. But in case he goes in for hypotension, you can always replace the fluid and increase the volume and maintain his hemodynamic stability. Now the second method, which is called hemodialysis, again there is a kidney or there is a filter, again there is a semi-permeable membrane, but blood comes in one direction, there is a fluid going in the opposite direction. And here the filtration is mainly by the concentration gradients of the substances. So you can see this is the blood side, and you can see these white dots, they are plenty in number. So whatever, if supposing this, imagine these are all urea particles. There are a lot of urea particles. Because of the higher concentration of urea particles, They will go into the dialysis fluid where there is no urea at all, and the removal here is mainly based on the concentration gradient. And this process is called the diffusion process. So here it is convection process, here it is diffusion process. And that is the difference between hemodialysis and hemofiltration. So again here blood is pumped through an extracorporeal system that incorporates a dialyzer. Here there is an extra fluid pumped into the kidney. Blood is separated from a crystalloid solution which is called the dialysate by a semi-permeable membrane, and solutes move across the membrane along their concentration gradient from one compartment to another, and the law which determines that is called the Fick's law of diffusion. The dialysate fluid runs in a countercurrent fashion, just similar to the countercurrent mechanism that is there in our normal nephrons to concentrate the urine volume. So to maintain the efficiency, when removal of water is required, the pressure on the blood side of the membrane has to be increased, forcing water and molecules to pass into the dialysate. So this is this method is called the, and if you combine both these techniques, the hemofiltration or ultrafiltration with hemodialysis, then it becomes hemodiafiltration. It combines the mechanisms of both. So these are the two basic initial mechanisms which were incorporated in hemodialysis part of mechanism. And this is another picture to show you how these things are being done. The first picture, as all of you know, from the patient, the blood goes into the kidney, and here there is no other fluid or anything pumped into that. There is whatever has been filtered by the hydrostatic pressure, the fluid comes out, and the rest of the blood is pumped back into the patient. And if necessary, you can add the fluid here before you pump the blood into the patient. This is the post-filter replacement fluid line. Sometimes if you want, you can dilute the blood. If the concentration is there and the patient is dehydrated, you can supplement the fluid in the pre-filter replacement of the level also. So this is the ultrafiltration or hemofiltration technique. The second picture, this is much more easier for you to draw in the exam. So again, blood comes from the patient into the filter, and there is a dialysate fluid which is coming in, which is running in the opposite direction. And once all the exchange has taken place by concentration gradient, the filtrate fluid or the used up dialysate fluid is removed here, which is called the effluent. And patient, the rest of the blood is pumped back to the patient. When you combine both you have to give pressure as well as dialysate fluid, then it becomes what is called the hemodiafiltration. So this is ultrafiltration, this is dialysis, this is a combination of both, which is called ultrafiltration and hemodiafiltration. So this is another picture to show you the same thing where convection and diffusion are taking place. And here the excess fluid from the blood comes out as an ultrafiltrate, whereas here there is a dialysate fluid going in, dialysate inflow, and the effluent outflow is there. So here this is an empty space, whereas here it will be filled with the dialysate fluid, and both run in opposite direction. Patient's blood comes from this side and goes out, whereas the dialysate fluid goes from here and comes out in this direction. So there is a countercurrent mechanism, and these are all the various sizes of molecules which are being removed from these mechanisms. Now to do this filtration, you need a vascular access. Unless you take the blood out of the patient from his body into the extracorporeal system, you cannot clean it up and pump it back into the patient. So you need a hemodialysis vascular access, and commonly AV fistula is created if you have time, especially in CKD patients who are being observed to see whether they can manage on their own urine output and maintenance of milieu interior. But ultimately, you feel that they will require replacement therapy at some time or other. You create a fistula by connecting a artery and the vein, and usually at the wrist level between the radial artery and the cephalic vein. And this will be allowed to mature for 21 days. As soon as you prevent the communication, you cannot use it immediately. You have to allow it to mature, and you will feel a thrill because the artery is pumping the blood in higher pressure to the vein. Once you successfully create a fistula, if you just put your hand there, you will feel the thrill that is going on because of the high pressure. And this is the way it is created. At the wrist level, this is the hand. You make a communication between the vein and the artery and create a flow. So because of the high pressure in the artery, it will flow into the vein. And over a period of time, all these veins will become dilated and very prominent. And this is called the arterialization of the vein. By creating this fistula, you create a higher pressure locally in the forearm veins, and all of them will bulge out and stand out, and you can puncture them easily and draw blood from them using a pump, and then filter it and then push it back into a vein so that the blood can be purified in that way. So this is the commonest method that is done for patients with CKD. If supposing this fistula, some patients may not have a adequate size vessels in this level, then you go for the brachial artery and cephalic vein at the elbow. And even if these vessels are also very small, you can use an artificial vortex graft to create the communication between the artery and vein. So this is how the communication is usually done at this level, at the cubital fossa level between the cephalic vein and brachial artery, whereas here it is the radial artery and cephalic vein. And if the veins are and the vessels are very small, you can use the vortex graft to create an artificial communication. But if the patient requires a dialysis urgently, then you go for IJV insertion of a cupped W tube or a through a subclavian vein or IJV, you have to insert this. So normally many of you would have seen in the ICU patients being inserted with this cupped catheter which goes into the, this has two lumens and it has got color markings to show which will be the arterial end and which will be the venous end, so that you draw the blood from the venous end into the machine, filter it, and then pump it back into, you draw the blood from the arterial side into the machine, filter it and pump it back into the venous line, so the whole blood goes into the patient. So these are the various types of vascular access which are required if you plan to do a filtration of the blood or renal replacement by hemodialysis method. Now this is the overall view of the entire process of hemodialysis, where you can see this is the fistula will be there, and the blood is drawn from the venous side into the system. There is a roller pump which goes in, and you can add heparin here, or you can inject heparin systemically to keep it anticoagulated. And there is a pressure monitor to show that there is no excess pressure or block in that. Then it goes to the dialysate, and the dialysate fluid goes in through this compartment in the opposite direction. Blood is going in this direction, and once the filtration is done, it comes out to the discarded collector, and the purified blood comes again back to the patient through the same dilated veins that have been created by the AB fistula. So there is a, this is the whole thing, and you can add the saline solution either here or in the in this line here also, that can be added depending upon the amount of volume that you want to replace. Now, hemodiafiltration is a combination, as I told earlier. It involves both the filtration as well as dialysis. Whereas the third technique, which is called slow continuous ultrafiltration, is used only when water removal is required. And this is what is called slow veno-venous hemofiltration, or the other technique is slow veno-venous hemodiafiltration. But the basic thing, so to understand all the advanced modes of renal replacement therapy, first of all, you should have a clear concept of the basic mechanism of hemofiltration and hemodialysis. If once that is understood, then these things are all just slight modifications of this which happen in these patients. And the difference is in hemodialysis and hemofiltration, you take out a large volume of blood and purify it and pump it back into the patient. Whereas in slow continuous ultrafiltration, you take out small volumes and do it continuously for a longer duration of time. So when will you do that? If the patient is hemodynamically stable, you can draw 350 to 500 ml of blood each minute, pump it, purify it and pump it back. But if the patient is hemodynamically unstable, removal of large volume of blood will make him further deteriorate. So in order to sustain or do the replacement therapy in hemodynamically unstable patients, it is better to go for slow continuous ultrafiltration. And you require anticoagulation for all these processes. And what are all the methods of doing that anticoagulation are? One is non-pharmacological method, where you adapt to reduce the clot formation. For that, you must have an adequate CVP pressure, you must have a good vascular access, and you can add a portion of replacement fluid to the patient before it passes through the hemofiltration, which is called pre-dilution. So if you have these three things, adequate CVP pressure, adequate vascular access, that itself will be able to push the blood without getting clotted through the filter into the machine. Now but you cannot rely on this non-pharmacological method always. They are helpful if you have these three conditions, but they cannot be the sole method of maintaining the anticoagulation. So in addition to that, you require what is called the pharmacological ways of anticoagulation, where you can use unfractioned heparin or low molecular weight heparin. And the dose of that is 40 to 70 international units per kg as a bolus of unfractioned heparin by the pre-filter infusion, followed by the pre-filter infusion at 5 to 10 kg, 5 to 10 international units per kg per hour. So I showed you in the earlier picture, there was a pump to infuse heparin into before the blood enters the filter, where it should be anticoagulated so that it doesn't clot in the semi-permeable membrane of the filter. So this is the first method. The second method, if you are using low molecular weight heparin, then you can use which is mostly used in intensive care unit patients, where they will be already receiving this. You can continue with that dosage and you can use that as an anticoagulation method. And the half-life is slightly longer compared to unfractioned heparin. So unfractioned heparin has got a half-life of only 1.5 to 3 hours, whereas this is about 2 to 6 hours, and their effect can only be the disadvantage of low molecular weight heparin is they cannot be reversed with protamine and they are renally excreted. So majority of the times, the only indication where we will use low molecular weight heparin is if they are already receiving this as a part of intensive care treatment to prevent a DVT or a pulmonary embolism, then you can continue with LMWH. Otherwise, we generally prefer low molecular weight, unfractioned heparin, because that has a shorter half-life and you can reverse its effect with protamine. The second thing, if there is any contraindication for heparin usage, then you can go for prostaglandins, which is a form of prostaglandin E2, which inhibits the platelet function and can be either used alone or in combination with heparin, where it will have a synergistic effect, so you can reduce the dose of heparin. And they have a very short half-life, so they have to be always given as an infusion of 2.5 to 10 nanogram per kg per minute. And the anticoagulant effect stops automatically on its own within 2 hours of discontinuing infusion. So you don't have to reverse their effect like what you do with the protamine as you do for heparin, and it is a good alternate for patients who are at a higher bleeding risk. Prostaglandin is a good choice. The side effects of this prostaglandins are it can cause vasodilatation, reduces the hypoxic pulmonary vasoconstriction effect, leading to hypoxemia, and they are costly. They are not that cheap like the other two drugs, and they are used only as a second line therapy. So these are the three disadvantages. One is it interferes with the hypoxic pulmonary vasoconstriction and cause hypoxemia. They are expensive and they are not the first line of drugs for usage. And the last method is what is called the regional citrate anticoagulation, where sodium citrate, which we normally use for keeping the blood in an anticoagulated state, and when you collect the blood from a patient for transfusion, blood donors, you add sodium citrate to keep it in an anticoagulated state. So the same can be infused in the circuit before the filter enters, and it chelates the calcium and inhibits the clot formation. But the disadvantage is because hypocalcemia, hypomagnesemia, hyponatremia, metabolic alkalosis, or sometimes acidosis by the citrate itself, and especially in liver failure patients. So even though this is one of the other alternatives, it is not commonly used because of this. So there is no evidence to suggest any new heparin alternatives like danapride or pyridine or fondaparinux or orgatroban are better than this. So conventionally, we have been using only heparin as an anticoagulant before the blood enters the filter. And we should give adequate time for it to act so that it will be in an anticoagulant. Now, a few words about the filter. They should be biocompatible and they should have less activation. As you all know, whenever the blood comes out of the body, whether it goes into the cardiopulmonary circulation or whether it goes into the ECMO or a dialysis filter like that, it will all cause an inflammatory reaction and it will activate the coagulation pathway. That is the reason why we give anticoagulants. And there are few the filter qualities. One, it should be biocompatible. Second, it should have a proper flux. What does the word flux mean? It means the permeability of the filter. So the high flux membranes are hydrophobic and have more larger pores, allowing more water and more larger substances to form, go through that. So the semi-permeable nature will have allow more water and more larger molecules to go out. So the flux is very important. The third point is absorption. Some of them absorb the large solutes to the surface of the membrane, and this will so mid-sized molecules causing inflammatory mediators may be removed by this filter itself. And the last thing is thickness. Thinner the membrane allow greater movement of the solute by diffusion and favor convection movement. Lastly, the surface area of the membrane determines the available area for diffusion and ultrafiltration. And most of the filters are made of cellulose based. It can be synthetic. And the synthetic filters are made up of a substance called polysulfone or polyamide, which are more biocompatible. And the modalities of RRT based on this, it can be intermittent, where you have to do the dialysis once in 2 days or 3 days as you do in CKD patients. It is mostly intermittent. You can do it continuous, especially patients in ICU with sepsis or other indications. There are, say, various types of continuous filtration, or it can be a combination of both, which is called the hybrid technique. Acyl state and ester. So these are the three modalities. Coming to the next modality of peritoneal dialysis, the dialysate fluid which is used in hemodialysis is modified and a large volume of dialysate fluid is pumped into the peritoneal cavity by gravity. So there is no need of any artificial pumps or anything to push the volume into the peritoneal cavity. And the peritoneal membrane acts as the dialysate membrane here, or the semi-permeable membrane that is used in the artificial kidney. Your own body peritoneal membrane acts as the uh, filter. So the dialysate goes in, number one, the fluid goes in here. It is allowed to dwell or remain there for 3 to 4 hours. After the fluid goes into that, about 3 to 4 liters of fluid will be usually pumped into that, and this line will be clamped. And then you allow the fluid to remain there. You can even disconnect it here and then attach the removal connection later on. So after 3-4 hours, what you do is you connect it again and let all the fluid close this line and open this line. Of fluid will drain by gravity into the collecting bag and the fluid is out. So very simple: in, dwell, out. These are the three mechanisms that the three steps that happen. And because of that, all the fluid and waste products are dialyzed from the patient. But this is a very good technique for patients who cannot come to hospital and lie there for 3 to 4 hours to do hemodialysis and get it done. So it can be done at home. And the mechanism how it does is in the bloodstream, it is mainly by the concentration gradient, just like what is happening in your dialysis. It is the same thing. Bloodstream contains a lot of excess water as well as electrolytes, urea, and other things. So whatever has to be removed, all the excess things comes out through the peritoneal membrane into the peritoneal cavity and you drain it out. So as simple as that. So the filter comes in, and indications for PD are patients with CKD who cannot tolerate hemodialysis, unstable patients, especially who cannot tolerate anticoagulation, patients with chronic infections, vascular access problems, and often the treatment of choice for older patients. And because it's more flexible, it can be done at home and frequently. And the contraindications for PD are any peritoneal surgery or earlier admissions, extensive intra-abdominal surgery which has already been done, obesity, recurrent episodes of peritonitis, abdominal malignancies, or patients who have respiratory distress or other respiratory problem, or ruptured diverticulum. These are all the contraindications. Now, advantages and disadvantages of PD. Advantages are it is very easy to learn. In fact, one of my cousin who passed away last year was on peritoneal dialysis for almost 5 years at home, and his wife was doing the peritoneal dialysis. During COVID time, he went to Bombay and he had to be hospitalized. And in a very leading corporate hospital, none of the nurses know how to do the PD. His wife was permitted to go with all the PPE and then the dialysis performed. So it is such an easy technique, but if you are not well versed with that, you can't do that. It can be done at home, and patient can be mobile. Once you put in the fluid, you clamp and disconnect, then the patient can be ambulance. And it has a better BP control because you are not removing any part of the blood from the body, and with less dietary and fluid restriction, greater freedom in scheduling and traveling also. And we used to fly and go to various places. And the disadvantage, it is time consuming. And sterile techniques are very much required. Otherwise, the chances of peritoneal infection is very high. And we should have the catheter permanently. The risk of peritonitis is there, contraindicated in abdominal surgery. Now, there are different types of peritoneal dialysis, just like you had the hemodialysis. One is called CAPD, continuous ambulatory peritoneal dialysis. The second is called automated peritoneal dialysis, where blood will be pumped out mostly during the night time so that the patient can be free during the daytime, and this will be pumped into the peritoneal cavity and removed automatically. Then intermittent peritoneal dialysis. So usually we do through 2 or 3 cycles in a 24 hours time for peritoneal dialysis. And this continuous cycling is done usually at the night time when the patient is sleeping. All the 3 cycles can be finished during the sleeping time without interfering with the patient's work during the daytime. First, again, the complications earlier also I have given dialysate leakage. And these are all acute complications because of the technique. Peritonitis, bleeding, bladder perforation, pain, and bowel perforation. Now, how do you assess whether the patient is adequately dialyzed and is responding to the renal replacement therapy? That is done by measuring what is called the fractional reduction of burn with each dialysis. So you measure the volume of adjusted fractional clearance of urea, for which the formula is K multiplied by T divided by V urea, where K is the dialyzer urea clearance. That you can measure the urea content in the dialysate fluid, the time on dialysis. So both of them are multiplied and divided by volume of distribution of urea. And and the measurement of urea removed through each dialysis also can be calculated by percentage reduction in urea during single hemodialysis treatment by urea reduction ratio. So the formula for that is 1 minus post-dialysis urea concentration divided by pre-dialysis urea concentration. This you multiply by 100, you will get the percentage reduction. So either of the methods can be used to assess the adequacy of dialysis. What are the care that you have to follow for hemodialysis patients? The dialysis dose urea kinetics model can be used, and the fluid balance individual intradialytic weight gain should be less than 5% of ideal body weight. This is very important. Otherwise, the patient will go in for hemodynamic instability. Quality, measure the endotoxin and bacteria in the dialysate water. Anemia, target hemoglobin of 10 to 12 grams. Avoid high dose erythropoietin. Vascular access to be constantly monitored to establish a good AV access with a mineral catheter or by fistula. Bone and mineral calcium levels have to be maintained and phosphate levels also to be frequently checked. Blood pressure should be optimum. The strategies to be adequate so that he is not in hypotensive state. And the LDL cholesterol should be less than 100 milligrams. The quality of life indices support for all medical and social workers. And these are the comparisons of the various types of modalities, mechanism of solute removal, duration, dialysis flow. So this chart will be useful to to go through that before your exams so that you can compare all that. And the how to choose what type of RRT is. First thing is hemodynamic stability. Second is fluid overload, whether there is any acute intracranial injury or hypertension, or whether there are any life-threatening conditions. These are the 4 things which you have to look into the patient. If the patient has hemodynamic instability, the first option is continuous renal replacement therapy, not intermittent hemodialysis, or SLED, slow efficiency daily dialysis, and our second option is peritoneal dialysis. Because we are not taking the blood out of the patient's body, peritoneal dialysis is much more safer. The third option only is intermittent hemodialysis, either through an IJV or a subclavian catheter. And if it is fluid overload, to remove that first option in a again patient with a lot of fluid overload or during surgery, we can do it by CRRT SLED. Second option is IHT, and third option is only PD. For acute intracranial injury or hypertension, CRRT or PD is the first choice, and then PIRRT or IHT as the third option. And life-threatening conditions like severe acidosis or in a patient who is having uremic encephalopathy, or patients with acute pulmonary edema, IHP will be a better choice. And then comes the PIRP, PRRP, and PD. Now, what is this? Comparison between SLEED and PRRP, can see it later on because of want of time. I'm not going to read all that. And the newer method is what is called the prolonged intermittent renal replacement therapy. And, this is compared to the continuous flow renal replacement. You can do prolonged intermittent renal replacement therapy, which is an alternative benefits to both CRRT in terms of hemodynamic stability as well as cost effectiveness. And the efficacy of the therapy with the daily session is higher with than intermittent hemodialysis or continuous veno-venous hemodialysis. Now, of course, peritoneal dialysis is another point that is helpful in hemodynamically unstable and fragile patients. It is an ignored modality used earlier in the acute kidney injury patients. And patients with higher bleeding risk for children, especially neonates, small children, post-cardiac surgery, acute kidney injury, and hemolytic uremic syndrome are all indications for peritoneal dialysis. So,